Hello. Hi, everybody. Am I audible from the participants? Anybody?
Yes, ma'am, you're audible.
Okay, that's good. So I hope everybody who has participated in today's session, I welcome you all, both in person and online participants. I'm Dr. Jannat Akter Riva. I'm currently doing my fellowship training program in internal medicine at Bangabandhu Sheikh Mujib Medical University. And I have completed MRCP Part 1 and Part 2, as well as I did my full-time master's in University College London under the at University College London on infectious disease epidemiology, which was fully funded by the Commonwealth Scholarship. And today we have started discussing about the cardiology the week before previous week actually. As I felt sick, so I could not really take the class in meanwhile. But in the first class, we discussed about cardiology, the physiology particularly, as well as how many questions come, what are the question banks you should go through, and what are the resource materials, as well as we have discussed about the congenital heart diseases, as well as the valvular heart diseases. So our today's topic of discussion is mainly cardiac arrhythmia, which is very important. You can expect around maybe 4 to 5 questions from cardiac arrhythmia, and as well as you will be able to get some questions from our next topic of discussion, which is actually the most important part and basically the bread and butter of the cardiologist, and that is the ischemic heart disease, or the coronary acute and chronic coronary syndrome. And I think the management of this is very important, not just from MRCP Part 1 or Part 2 point of view, but at the same time, it's an emergency condition, and everybody, even practicing internal medicine or GP practice, they should have a very concise and clear idea about the management of the coronary syndrome. So these are the two most important topics that I will go through. In our third class, we will discuss about the heart failure, cardiomyopathy, as well as the cardiac catheterization interpretation. And in the final class, we will try to wrap up all of the discussions, as well as we will discuss about the hypertension, pulmonary hypertension, and aortopathies. Okay, so does anybody have any question for me at this stage? Please let me know. Okay, let's see how many participants are here today online. I can see, I can appreciate that there are 2 participants in front of me, Dr. Deep and Dr. Ovijit. Sorry, Dr. Kobir. Okay, and I hope you guys went through my previous recording. And today I will be discussing about the cardiac arrhythmia, which I've just mentioned. And I can see that there are some participants online, Dr. Anupam Bishwas. Dr. Anupam, can you hear me?
Yes.
Okay, where are you based at?
Sorry?
Where are you from?
Now I am in Sylhet.
You're in Sylhet. Okay, all right. So I hope that you'll be able to go through the entire class, because we have some interactive question answer session. And today, I think because the topic is quite complicated, so instead of single-handedly asking you guys, I will go through these questions by myself also, and this will be like a group discussion. And next, I can appreciate Dr. Abu Taslim. Can you hear me? Hello? Dr. Abu Taslim, can you hear me? Okay, perhaps not. Dr. Neha Singh, I hope you can hear me.
Yes, ma'am.
Okay, are you joining from home or from the ward?
No, today I'm at home.
Okay, that's good. So that means that you'll be able to go through my lecture without having any interruption.
Yes, ma'am. Yeah,
okay, that's really good. So we have Dr. Abu Taslim back. Maybe you're having some technical difficulty. It's fine. I will probably ask some questions when we're discussing. That's all right. So Dr. Anupam Bishwas, did you take any class in person before?
Actually, this is my first class here. But previously on 2018, I have done few class on MRCP Part 1 exam, but my study was irregular. So
Okay.
now I am again here.
That's entirely fine. I can understand. This can happen. Adult learning is very difficult. Post-graduation training, as well as earning something, some money, doing your duties, making, like family demand and everything. There's too many things going on in everybody's plate. So it's completely normal. Do you have any plan to sit for the part 1 examination anytime soon?
I have planned in next January session to sit in
Next
part 1.
January session, 2024, right?
Yes.
Okay, that's great. All right, I will just go straight. Thank you so much, and we will start our discussion today. So cardiac arrhythmia. Does anybody have any idea what the arrhythmia means? Okay, Dr. Deep, can you tell me, when somebody talks to you about cardiac arrhythmia, what's the first thing that comes to your mind?
Any changes in the heart rate,
Mm-hmm.
like irregularities in the heart rate.
Okay, rate or rhythm problem. Okay, all right. And what's the commonest cardiac arrhythmia that you deal with? Or you have dealt with? Doesn't matter, not the statistical bit. You have dealt with.
AP or bradyarrhythmias, those kind of things.
Bradyarrhythmia and atrial fibrillation, okay?
All I can remember from my blog posting or my intern
Mhm.
CCU.
Okay. I think those are two of the most commonly encountered cardiac arrhythmia. Okay. Dr. Kobir, have you ever encountered with cardiac arrhythmia? Sinus tachy, okay, very good. Very common. Atrial fibrillation, okay, that's fine. Any other cardiac arrhythmia that you have encountered so far? Okay, maybe you're lucky. Anybody from the online? Have you ever encountered any cardiac arrhythmia?
Ma'am, supraventricular tachycardia in heart block
Supraventricular
patients,
tachycardia. Okay,
in
and which
atrial
one?
fibrillation, in the
AFibs,
heart block patients, ma'am.
heart block, okay.
And atrial fibrillation is the most common that even I have encountered.
Okay, all right. And anybody else from the online participants would like to add anything, any experience? I just want to learn. I'm not trying to know like what's the commonest cardiac arrhythmia or something. This is not a question answer session, just your experience. Anybody else? Okay, has anybody ever dealt with ventricular tachycardia? Anybody?
Yes, ma'am. Yes, ma'am. Very
You have dealt
regular.
with
Yeah.
ventricular tachycardia. Okay, so you're
Yeah.
one of those unfortunate ones. Were you able to give the management or did you refer the patient?
No, 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 no. We manage the patient at the hospital itself. We mostly like,
Okay.
if it is, we try to give the cardiogenic shock, try to
Mhm.
afibrillations, like, what fibrillators actually. We try to use that also to control the heart rate and everything. And
Mhm.
also, we try to manage with digoxin.
Digoxin, okay, all right.
Yeah.
So it's a bit, maybe in atrial fibrillation, there is indication of digoxin, yes, 100%. But in ventricular tachycardia, you cannot give digoxin. But yes, if the patient is hemodynamically unstable, then there is always indication of going for the DC shock. Okay, thank you so much, everybody, for telling your point of view about the cardiac arrhythmia. So I will just try to go to my blackboard, okay? All right. So cardiac arrhythmia, I'm just gonna draw like a bit of heart again. And you can see these are the 4 chambers. This is where the SA node is located. This is at the junction. This is where the AV node is here. This is the bundle of His, and this is the right bundle, and this is the left one. Okay, and you can see these are within the ventricular endocardium, and the myocardium goes the Purkinje fibers. Okay. All right, so this is just a very basic childhood. We have all gone through this conduction pathway, electrical conduction pathway back in our undergraduation level. Like the pacemaker of the heart is known as the SA node, which the sympathetic and the parasympathetic nerve endings are here located. And this is where the magic happens. This causes contraction of the heart muscle, as well as maintains the electrical impulse within the entire heart, which is then again is responsible for the cardiac output, as well as the perfusion, as well as the cardiac contractility. So many important things are dependent on this single conduction pathway. No other organs in our body have this auto-generative electrical conduction system, right? So from the SA node, the electrical impulses go towards the AV node, and AV node is kind of like that guard who kind of like keeps it safe, you know, like maybe the SA node, you can consider the SA node as being the teenager, the source of youth, the source of energy, responsible for the generation of the electrical conduction. But the AV node is kind of like an adult who knows that to what extent the electrical conduction should pass from the atrium to the ventricle. Because if somewhat there is some sort of block, it can either, what happens is, it can either slow down the cardiac heart rate, and if there is some accessory abnormal pathway, then there might be some increased electrical abnormality, thereby causing more and more ventricular contraction and making the heart fatigued, okay? So the AV block is kind of like the adult who keeps everything under check. So all the impulses that are generated from the SA node goes to the AV node, and AV node then gives it a pause, you know, like this gives it a pause, and then regulates the electrical impulses from the atrium to the ventricle, so that a smooth contraction is maintained throughout the cardiac cycle. And from the AV node, the same generated impulses will go down the bundle of His, and then in the left bundle His, it kind of takes a bit of alteration pathway, like it takes a bending from going from the right to left direction, okay, because of the septum. This kind of delays the impulse slightly. And then in the right side, you can see the bundle, right branch of the bundle of His, and this is the left bundle of bundle branch. And on the left side, this is further like divided into two parts. This is the anterior one, and that's the posterior fascicular. And from there, there's the Purkinje fibers maintaining the ventricular contraction. So that's the basic anatomy or the importance of cardiac conduction. So what does arrhythmia mean? Arrhythmia means when the heart is not working, when the electrical activity of the heart is not working within normal limit, okay? So broadly speaking, the arrhythmias can be of two types, okay? A lot of people would debate with me, but I try to simplify things. So I usually consider whether this is a supraventricular originated SV origin or whether this is a ventricular origin. Okay, so what are the important things that you should consider before checking cardiac arrhythmia? Okay, number one, I've told you what's the supraventricular origin or the ventricular origin. Number two, very important, clinically stability, whether the patient is clinically stable or not. And how can we say whether the patient is clinically stable or not? We check the pulse and the blood pressure, okay? So if the patient is hemodynamically unstable, then there is no other option for consideration of any other drug apart from DC shock, okay? Remember this. So I'll come to this point a little bit later on. So important thing, we should first check from where the arrhythmia or the abnormal electrical impulse is generating, whether this is supraventricular origin or this is ventricular origin. Number two, whether the patient is hemodynamically or clinically stable. So unstable patients would have low blood pressure. So the blood pressure would be less than, systolic would be less than 90 over, and the diastolic would be less than 60. So 90-60 is the cutoff value. And pulse can be either two types. It can be either a bradycardia, less than 50 beats per minute, or tachycardic, more than 100 beats per minute, okay? And number three is, we will consider some risk factors. What are the risk factors? For example, if the patient has like some ischemic heart disease or any other or structural organic heart disease, like for example, cardiomyopathy, left ventricular hypertrophy, or ischemic heart disease. Okay, so these are the structural or organic heart disease. That's a risk factor. Number two, increase in the age. Okay, so the older you are, your heart already does not work as that good as in a younger patient. So the more chances of you that the arrhythmia will take longer time to restore into the sinus rhythm, okay? Number 3 would be other comorbidities such as uncontrolled hypertension, diabetes for a long time, CKD or kidney impairment, and smoking. This is a risk factor, or dyslipidemia, DL, and family history of ischemic heart disease. Okay, so these are the important risk factors, as well as if there is any concomitant heart failure. So that means if the left ventricular ejection fraction is less than 50%. Okay, so concomitant heart failure, this actually adds to poor outcome related to any type of cardiac arrhythmia. So far, do you have any questions? This was a very generalized discussion. Okay, all right, next one. All right. Next discussion is, so a patient comes to you with any type of cardiac arrhythmia. We have discussed like what are the things you should look for. So how do you go for our assessment of cardiac arrhythmia? The first thing you should do is you should do a 12-lead ECG. While you're doing that, you should check the patient's vitals, okay, pulse and blood pressure. And then you should hear over the precordium, check the precordium, check precordium. Why? Because whether there is any device fitted or not. For example, there might be some implantable cardiac defibrillator, there might be some chronic resynchronization therapy or CRT device, there might be some pacemaker inserted, there might be CABG scar mark, which is kind of like, looks like this in the chest. There is a midline sternotomy scar mark with vein harvesting scar mark. So these are the things that you should assess. Number 3, check whether the patient is wearing any medical or bracelet, okay? So that might indicate the patient has some sort of emergency condition going on. And you can, if the patient has already cardiac arrest or collapsed, then from the medical alert bracelet, you can get a lot of information. For example, whether the patient is diabetic, whether the patient is taking insulin, whether the patient has any allergy to any particular medication. These are the some of the important information. In our country, we don't really have the medical alert bracelet, but in the developed countries, we do so. Okay, number 3 is check the patient's oxygen saturation. Very important, because at the end of the day, when your heart is not beating properly, then all the organs in your body will go into hyperperfusion state, okay? And you might also experience oxygen lack, and thereby causing downgoing of the oxygen saturation. And then try to auscultate the lung base, okay? Because there might be auscultation of the lung base, because to rule out if there is any features of acute left ventricular failure. And then check the legs to see if there is any edema. Also, these are the important things that you should consider, okay? But then again, if the 12-lead ECG is somewhat normal, but clinically the patient has complained of palpitation or racing and pacing of the heart, then what you can do is, and the patient is clinically stable, you should not let the patient go back to his home, okay? You should keep the patient under observation. You should closely monitor this person. And considering the risk versus benefit ratio and the presence of comorbidities, the next best investigation should be done is Holter monitoring, okay? So can anybody tell me what is the commonest manifestation of cardiac arrhythmia? Commonest complaint, physical complaint. Palpitation, okay. Second one? Second? Shortness of breath, excellent. And third one?
Dyspnea on exertion.
Sorry, loss of consciousness, exactly, or cardiac syncope. And fourth one, if you have to put anything.
Dyspnea on exertion.
Yes, dyspnea has been discussed. So palpitation, shortness of breath, cardiac syncope, these have been discussed. Any other complaints patient might have? Dizziness or pre-syncope, right? So before the patient falls, the patient might feel clammy, sweaty. Patient might complain, I do not feel well in myself. What exactly is happening? I feel sort of dizzy, doctor, okay? Something is not happening right. So what exactly do you feel? I feel like my heart is beating in such a way that I feel it's difficult. When I stand up from the sitting position, I feel like I'm having vertigo. I'm about to fall. When I exert myself, I feel this is more. So these are the complaints a person would give you if the patient is having some sort of cardiac arrhythmia. Okay. So our next topic of discussion would be, so look at the ECG. So look at the ECG. What do you want to see? First of all, check the QRS. First actually go through the rate. Okay. It can be tachy. It can be brady. This can be sinus. This can be, that's actually within the rhythm. So this can be sinus rhythm or this can be irregular. Okay, and then this is the first one, this is the second one. In any ECG, we do look at the standardization, okay, but that's mostly important. The standardization is actually mostly important for the left bundle branch block as well as for the MI diagnosis, okay. And the third one that we check is the QRS duration, whether this is a broad complex or a narrow complex. So in any events of cardiac arrhythmia, these three are very, very, very important to look at. All right. So what are the differentials for broad complex and narrow complex? So broad complex, divide this into regular, and the other one would be irregular. So within the regular, the most common broad complex regular tachycardia is ventricular tachycardia, okay, VT. Unless and otherwise proved. Because never, ever, ever overlook VT. This is actually a peri-arrest situation. If a patient is having ventricular tachycardia, so that means the patient can deteriorate rapidly. The patient can have ventricular fibrillation, and you may not have the time to save that person's life, okay? So ventricular tachycardia is very, 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 very bad. And I cannot stress how much bad this is, okay? Number two is, and the other differential for the regular broad complex would be SVT with aberrant conduction. But then again, if you're not sure whether this is a ventricular tachycardia or whether this is supraventricular tachycardia with aberrant conduction, do treat it as a ventricular tachycardia, because in that way you will be able to save a person's life. Okay, and the irregular one, and if it is broad complex, then consider two possibilities, okay? One is atrial fibrillation with bundle branch block, bundle branch block. And if this is irregular, another common possibility is polymorphic VT. Polymorphic VT. And I don't know how many of you have encountered this in your clinical practice. One of the common variants of the polymorphic VT is torsadus de pointes. Okay, so broad complex tachycardia, I do have a picture in my phone. I will try to show this to you because we just dealt with a patient with ventricular tachycardia. So that's why. Just give me a second. Okay, I'm not sure if you guys can see this. Okay, is it visible? Is it visible now? Can anybody see?
It's blurry, ma'am.
It's blurry, okay, okay. So I'll try to draw it for you guys, okay? It take two. That's okay. I think it's a better high. Because this ECG is quite important, so that's why I'll be trying to send this to the group, okay? Okay, I've tried sending the photos. But I will draw it at the same time. গিয়েছে না? দেখেন, আপনাদের mentor group এ আছে। Okay, so if this is the ventricular tachycardia kind of looks like this. Sorry? Okay. Can anybody see my screen? Is it visible?
Yes, ma'am.
Okay, this is the ECG for the ventricular tachycardia, okay? So as you can see, this is the regular, the rate is regular, okay? And then these are the very broad QRS complex. So treat it as a case of ventricular tachycardia. All right, the second picture is that in the ventricular tachycardia, okay, I'll discuss about this a bit later on. All right. So as I was saying, what was the last part? All right, so broad complex, and then we see whether the rate is regular or irregular. So if it is regular, it's almost always ventricular tachycardia. If this is irregular, this is either two possibilities. One is atrial fibrillation with bundle branch block, or the other possibility is polymorphic ventricular tachycardia. Within this, there is torsitis the pointus. All right. Next one is if this is a narrow complex tachycardia. Narrow complex. So narrow complex will just look like sharp, like this, minimal, very small gap of the QRS duration. Can anybody tell me what's the normal QRS duration?
Yeah.
120 millisecond. That's a normal, but there is a range, okay? So it can be 120 to 150 millisecond. If this is less than 120 milliseconds, so that's roughly less than 2 small square, then you should consider this is a case of narrow complex tachycardia. And if the space is roughly more than 4 to 5 small square or equivalent to 1 large square, then that indicates that this is a case of broad complex tachycardia. Sometimes there is some variation, but this is like the general rule. So narrow complex tachycardia, again, this can be of two types. One is the regular and the other one is the irregular. If this is regular, most likely this is a case of supraventricular tachycardia or the SVT. And if this is irregular, most common one is the atrial fibrillation, okay? And sometimes some debate that within the narrow complex tachycardia, atrial flutter can come, but I think that atrial flutter has its own uniqueness. So it's actually better not to be discussed within these two subgroups. Just remember the common things first. If this is a narrow complex tachycardia and the rate is regular, then this might be supraventricular tachycardia. And if this is a narrow complex tachycardia, but the rate is irregular, so this is almost always atrial fibrillation. Okay, so far, does anybody have any question for me? All right. So I think I will discuss about the advanced life support a little bit later on. But I'll just go through this broad complex tachy and narrow complex tachy. I've discussed about this supraventricular tachycardia. All right, fine. The photo, the way a supraventricular tachycardia looks, it's almost like this. But I think because of my drawing, it kind of looks like irregular rhythm. But imagine this happening in regular intervals, okay? So that's just like a supraventricular tachycardia. And the main treatment option for the supraventricular tachycardia is most of the time supraventricular tachycardia in the absence of structural abnormality or ischemic heart disease, it occurs most likely because of electrical imbalance, maybe dehydration, maybe stress or anxiety, or maybe alcohol. So there is actually a specific term known as the holiday heart syndrome, where patients, they usually consume large amount of alcohol or go for the binge drinking. And after that, then they might have this palpitation, sudden onset palpitation. You do an ECG and you get the narrow complex tachycardia occurring in regular interval. So this SVT is not a pathological finding. If you keep the patient under observation and then discharge the patient without giving any anti-arrhythmic drug, then that's the most important thing to do. These are the common causes for the supraventricular tachycardia. Management of the supraventricular tachycardia is actually relatively easier in a sense that first check the pulse and blood pressure. For any arrhythmia, if you see that the patient is hemodynamically unstable, then the first management is DC shock, okay? But apart from that, different cardiac arrhythmia have different approaches. So for the SVT, first important thing is to do is sometimes Valsalva maneuver can be quite difficult to do. So what you can do is you can go for the carotid massage, okay? This is where the carotid artery lies. And this is where you do this type of massage gently. And you should not occlude this, okay? The massage should be like a massage. You do not push it and occlude this. That will actually cause the patient maybe to die. So Valsalva maneuver or carotid sinus massage is important. Of course, keeping the patient in a resting, calming situation, as well as making the patient comfortable is another important thing to do. Number 2 is you can administer adenosine. Adenosine, this actually has a very short acting type of life. It lasts for maybe several seconds to several minutes. So you should give the loading dose of adenosine, which is 6 milligram. If the patient is still having SVT, go for double dose, which is 12 milligram. If the patient is having SVT, then you can double the dose and give 12 milligram again, okay? So this is 6, 12, 12. However, there is a contraindication. Contraindication is adenosine can cause severe bronchospasm, okay? So in a patient with asthma or bronchial hyperactivity, like maybe COPD as well, you should not give adenosine. Rather, you can go for the third option, which is verapamil. Verapamil is, what exactly is verapamil, Dr. Kobir? Calcium channel blocker, okay. Is it rate limiting? Yes, it's a rate limiting calcium channel blocker. All right. So that's the management plan for the SVT. And what if even after administering a verapamil and the patient is still having SVT, what was the possibility? What's the most likely possibility? Possibility is you might have misdiagnosed the patient. This patient actually has atrial fibrillation, okay? So after we have actually seen this in our clinical practice, we have followed this exact pattern, Valsalva or carotid sinus massage, adenosine 6, 12, 12, no clinical improvement. Patient has a background of chest infection or pneumonia. And then we have given the patient verapamil. And then after giving the verapamil, it kind of helped regulating the heart rate. So once the heart rate stabilizes, it shows the true nature. So we were able to see that the rhythm is actually occurring in irregular interval. So when the SVT happens, when the heart is like acting crazy and there is no interval, so sometimes it can actually mimic SVT and the rhythm can be happening at regular interval because there is in between the two beats, there is very bare minimum of pause, okay? So that's why it kind of showed like it seemed to us that it was actually regular. But after giving the verapamil, once the rate was controlled, we have seen that actually the rhythm is irregular. So you have to go back to the atrial fibrillation management scheme. I'll discuss in the last portion the atrial fibrillation management because that one has too many details, but I will try to simplify this, don't worry. All right, so SVT, all right. Now we will discuss about ventricular tachycardia. As the ventricular tachycardia is actually a peri-arrest situation. So this is actually a medical emergency, first of all. If you don't know what you have to do with ventricular tachycardia, do not keep the patient to yourself. Refer as soon as possible. Refer ASAP. Because once there is ventricular fibrillation, once VT develops into fibrillation, there is no chance that this can be reverted back to normal, okay? So try to revive the patient once that patient is having ventricular tachycardia. So call for help call 911 or 999 in the UK. I don't have any idea what's the Bangladesh emergency number. I have no clue. Basically, living or dying in our country, it depends on the God's will, to be honest. All right, call an ambulance. If you're working within a tertiary hospital, involve the seniors, inform the cardiologist. Refer. Okay. Now, if a patient with ventricular tachycardia, imagine, so the patient has ischemic heart disease. I'll give you a scenario, 70 years of age, male, ex-smoker. Okay, he had maybe anterior ST elevated MI 2 months back. Okay, now has complained of palpitation for the last 2 months, and it became worse over the last 24 hours. Okay, last 24 hours. You do an ECG, you see that the patient is developing ventricular tachycardia, and the patient's hemodynamics are, say, temperature is normal, respiratory rate is 20 breaths per minute, patient is having shortness of breath as well, and patient's pulse is 105 beats per minute, and the blood pressure is 90/55 millimeter mercury. So what do you want to do in order to save the patient? Like, for example, imagine you're working in the cardiology department. What do you want to do? What do you think?
Yeah, it has a history of cardiac arrest, not arrest, ischemic myocardial infarction. So it's considered.
Yes, of course. Why the confusion? Just because you're saying the word not 60 doesn't mean that the patient is not having hypertension. Of course, the parameters are abnormal. The patient has pulse more than 100 beats per minute. The blood pressure is 90/55. Doesn't matter. It's still hypertension, right? Anything less than 100/70, it is hypertension. So if we theoretically we say like less than 90/60, but it's usually equal or less than 90/60. Okay. So you should go for the ventricular tachycardia. It's an emergency situation. So in the best interest of the patient, do cardioverter, okay? Give DC shock. All right. So ventricular tachycardia, what are the ways you can tell for sure that this is actually ventricular tachycardia, but not SVT with aberrant conduction? First of all, the QRS duration will be more than 160 milliseconds. So this will be very broad. Number two, there will be presence of fusion beats or capture beats. I'll show you how the fusion beat or the capture beat looks like. Number three, positive QRS concordance. Now I'll show you what exactly is the concordance. Okay, this one, I think this is better. All right, you can see the QRS complex is very broad here. Unfortunately, this kind of gives the impression of a fusion beat, but we are not sure. Sometimes you cannot be 100% sure, okay? And what's the positive QRS concordance? I'm looking for a T wave here. T, okay, this one's a T wave. All right. So as you can see, if there is the TP segment is very much not really visualized, but from the generalized impression gives you that the compared to the S wave, the Q wave, or sorry, the R wave is actually higher, okay? So the the positive slope here This one actually goes higher compared to the downslope here. If you consider, maybe this is actually the TP segment that I'll show you. So the TP segment, what is a TP segment is actually known as the baseline. Okay, so any up sloping or any down sloping should be measured from the TP segment. So we will look at the rhythm strip. So we are seeing that most of this beats are actually taking from a single line. So if we draw this, if this is the TP segment or the basement line, so compared to the downward deflection, you can see the upward deflection is more. So do you agree with me? Okay, so that's basically, if you remember the normal P, this is the Q, this is R, this is S, and that's T, right? So usually in a normal ECG, the positive deflection, which is the R wave, is greater than the S wave, right? Unless there has been an MI, because sometimes with deep S wave, it usually indicates there might have been some infarction or maybe ventricular hypertrophy, some sort. So in normal situation, the positive deflection is more than the negative deflection. So here in the rhythm strip, if this is the baseline, you can see that the positive deflection indeed is more than the negative deflection. Okay, you agree with me, right? So, and then it's very difficult with the broad complex tachycardia, it's very difficult to visualize where exactly is the T wave. So we will look at this V2 precordial lead, okay? So if this is the QRST, this one's possibly the T wave, okay? And if the T wave is in the same line of R wave, or the deflection that has the most height, if the T wave is in the same direction, then that is known as the positive concordance. But imagine if we drew a baseline where maybe I don't have that photo here with the SVT with aberrant conduction, because that's a relatively difficult to find actually. But if you consider this is the baseline, okay, and this is the negative deflection, this is the positive deflection, here the negative deflection is more, and then in a normal precordial lead, you have seen that the T wave goes upsloping. So that actually goes against the most direction is going in the downward direction, okay? So this is in the opposite direction. So that is known as the negative concordance. So basically what exactly is positive concordance? Look at the rhythm strip, find out the TP segment or the baseline, then measure whether the height of the R wave is more or whether the height of the S wave is more. So positive QRS concordance is basically when the T wave will be in the same direction of the most heighted amplitude. That's known as the positive concordance, okay? I hope this was easy to grasp. Okay, all right. Actually, even I didn't know about this before I did my training, okay? So it was just a theoretical knowledge for me before that. All right. Next photo, we will try to show, the pathophysiology of the fusion beat and capture beat is quite difficult, but I will just tell you guys to just see, like have a look, like how does a fusion beat look like? So here, this is probably the fusion beat here, okay, this one. And in the previous one, there is no capture beat here, but a capture beat usually looks like after the broad complexes and the fusion beat, there is a normal QRS pathology. That one is the capture beat usually, okay? This one's a different one. All right. Oh no, I have to wipe everything off. Right. Broad complex tachy. So these are features that I was talking about: fusion or capture beat, positive QRS concordance, marked left axis deviation, and history of ischemic heart disease, QRS duration more than 160 millisecond, lack of response to the adenosine or carotid sinus massage. Of course, the ventricular tachycardia will not respond to the SVT maneuver. And AV dissociation is basically not every P wave Not every P wave will be followed by a Q wave. Okay, so you can see this is the P wave, this is the P wave, there is no QRS complex here. So this is basically the atrioventricular dissociation, which is also present in complete heart block. So just go through these findings. Like sometimes they can give you some true false question scenario from here. Like this patient has blah, 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 this scenario. So which of the following suggests that the patient is having ventricular tachycardia rather than SVT with aberrant conduction? So you should remember these points. Does anybody know what's the very easy way to say whether there is right axis deviation or left axis deviation? Yes. Yes, you should focus on 2 leads only, okay? 3 leads, 1, 3, AVF. If this is very general without going through the very detail of the axis, because the cardiac axis can be very tricky sometimes. So in general, look at the lead 1 and look at the lead 3. If they are in kissing pattern, like QRS complex is going upwards, and in the lead 3, the QRS complex is going downwards, that means there is usually right axis deviation. And you can also check the AVF as well. Sometimes lead 3 can be a little bit inconclusive. So look at the AVF lead as well. And for the left axis deviation, this goes in the same direction, okay? So if it is going in the same direction, it can either mean normal or it can mean left axis deviation. So how can you differentiate from the normal and the left axis deviation? That's actually for a cardiologist to know, okay? So for the time being, just focus on these 2. Like if it is going opposite direction, most likely this is right axis deviation. All right. Okay, drug therapy management. Go back to this one. So we have discussed about what makes VT different from SVT with aberrant conduction. Now, for the management purpose, management of VT, it's actually very, sometimes it can be quite straightforward as well, because you should give loading dose of amiodarone, okay? All this big talk just to give a loading dose of amiodarone, right? Simple. What's the loading dose of amiodarone? It's 300 milligram. In our country, they usually start off with 150 milligram. And then if the patient is not responding, within minutes, they go for another dose of 150 milligram. But for MRCP purpose, remember the 300 milligram dose, okay? And we usually wait for the ventricular tachycardia to go back to the sinus rhythm. So when we are trying to make the rhythm go back to the normal or the sinus rhythm, that process is known as cardioversion. Cardioversion can take place in both ways, chemical or electrical. Electrical cardioversion is done by DC shock, and chemical cardioversion are done by either amiodarone, maybe lidocaine, can be done by flecainides, these type of antiarrhythmic agents. So in case of VT, the choice of drug is amiodarone. And what are the drugs that you should never, ever, ever give in ventricular tachycardia? Number 1, verapamil. Never. Number 2, digoxin. Some cardiologists also debate on the use of beta blocker in ventricular tachycardia, because what it does is it causes myocardial suppression. Okay, they have negative inotropic effect, and they can actually cause atrioventricular block. And in the ventricular tachycardia, the heart cardiac output is already in a low, it's reduced, okay? So you do not want to further lower it down. So do not give any agents that will cause the heart cardiac output to go down. So verapamil is definite contraindication, as well as do not go for the digoxin. Beta blocker is plus minus, especially in high dose, or maybe non-selective beta blocker. Okay, and for the prophylactic basis, you should give cardioselective beta blocker in low dose and then titrate accordingly, not the non-selective ones. And implantable cardioverter defibrillator can also be given in patients to prevent the further episode of ventricular tachycardia. And these decisions are taken by the cardiologist. Okay. So, all right. And
Ma'am,
yeah, that's
could you
all about
please
the
repeat?
ventricular tachy. Sorry.
Could you please repeat implanted?
Yeah, ICD is implantable cardioverter defibrillator. Implantable cardioverter defibrillator. It's kind of like a very similar looking device like a pacemaker, but a pacemaker has two leads. Like if you see, this is the battery, and the pacemaker usually has two leads attached here. But in case of an ICD, it has only single lead. And then the lead here, this has a shock device, like a relatively in the chest X-ray, it looks a little bit wider compared to a normal lead, okay? All right. So I will go through the main points for the advanced cardiac support here. So what's very important for MRCP purpose. Okay, so Dr. Deep, imagine a person has come to you with cardiac arrest. What are the important things you would like to do? Do not assume that you're a cardiologist, like from a very general perspective.
The disease, check the pulses,
Mhm.
the breathing is going on.
Yes, very good.
Then if there is no pulse, call for help.
Mhm.
Then if you're alone, then start the CPR.
Mhm.
If you have help, then try, not in our context, but usually try to find a defibrillator as soon as possible.
Okay. And anything else you would like to consider? I'm very good that you're thinking of calling external help as well as ABC resuscitation, as well as consideration of CPR, because CPR can be given by the laymen also who are like trained in it. And any other things that might be going in your mind?
If there is any cause,
Reversible cause, try to find it out. Do the ECG at the same time, try to take a blood sample as soon as possible. And most important one is hospital setting, okay, no problem. And most important is keep the patient in recovery position, okay, until further help is available. All right, most of the points that you have covered. Now, if this is a pulseless electrical activity, then you should start to make the heart work again. So yes, you're very right, CPR is the thing to do, unless otherwise the patient already expressed DNA CPR, okay? But because that is a legal issue, do not attempt resuscitation. These things are very important. So the ratio of the chest compression to ventilation is 30:2. So you give 30 firm compression over the chest and then 2 breathing. And before the third shock, you should call the paramedics, or in the hospital, you should call for the help, and the paramedics will come with the defibrillator box. They usually go for like a bit lower joule, and then they level it up, like maybe 150, they start with 150, and then they go for 200 and 300, something like that, depends on them. But before the third shock, if the pulse, because of the pulses electrical activity, adrenaline 1 milligram is given, okay? Once the chest compression have restarted after the third shock. So, and then every 3 to 5 minutes, you can repeat this adrenaline. In our country, NORAD is given instead of adrenaline. So depends on the availability and the local guidelines as well. But for MRCP purpose, do remember this particular portion, adrenaline 1 milligram. And also amiodarone 300 milligram is also given after the third shock if the patient has not revived so far, okay? Atropine is no longer recommended. Atropine is only used in bradycardic situation, not in asystole. Okay, so the patient is still having some pulse, but it is feeble, and this is Brady. That's when you give atropine. If you get no pulse, go for adrenaline. Okay, there should be no confusion regarding this. And all right, we have discussed most of it. All right, this oxygen delivery, that's also important. In the emergency setup, you should keep the patient's like breathing tube patent. Keep the patient in recovery position. The patient might need some mechanical intubation whatsoever. And meanwhile, you should give the patient oxygen, blah, blah, blah. Try to keep the saturation within 94 to 98% unless otherwise contraindicated. Like for example, in COPD patient, there is hypercapnic injury. So try to keep the oxygen saturation within 88 to 92%. Do not give over oxygenate the person. But after that acute event has settled up, if the patient is able to maintain his own oxygen saturation, there is no need for further supplemental oxygen, because oxygen can also cause injury to the brain as well as the heart and the lungs. Okay, so after the acute event, if the patient is able to maintain their breathing, no role of supplemental oxygen. All right. So, okay, Dr. Kobir, can you tell me what's the first important drug in cardiac arrest that you should consider? Adrenaline. And what's the dose? 1 milligram. Okay, that's very good. All right. So, peri-arrest situation. Okay, fine. BT I've discussed. In the lecture book, I think there are some additional, slightly rare, kind of unimportant, but then again, for the exam purpose, there are some tachycardias that have been discussed. For example, like this one, the catecholinergic, even I cannot say it properly, catecholaminergic, okay, polymorphic ventricular tachycardia, the CPVT, that's the main issue. This is actually an autosomal dominant situation because of the genetic abnormality. This happens without any, in the absence of any ischemic heart disease, or maybe in the absence of any other factors, okay? So most important factor would be positive family history of similar condition before. And exercise induces this type of arrhythmia, can cause sudden cardiac death. And symptoms generally develop before the age of 20. So in a young patient, sudden collapse or sudden cardiac death, you should consider some genetic condition, okay? Not just this one, this is very rare. The most important genetic condition will be the hypertrophic obstructive cardiomyopathy, or the HOCM. Okay, treatment is just like that of beta blocker, VT, beta blocker in implantable cardioverter defibrillator. Okay. MAT is quite important because MAT, what happens in MAT is there are three distinct type of P wave, more distinct. Okay, what exactly is going on with me? Three distinct types of P wave morphology. So each of the P wave will look different from the other one, and you can at least identify three different types of P wave morphology. Normally, we know that the P wave looks like this. Okay, it's the P wave indicates atrial repolarization or the atrial contraction, right? All right, and actually, it has part from both of right atrium. This portion occurs because of the right atrium depolarization, and this one occurs because of the left atrium depolarization. Okay. And sometimes this is normal, okay? In the precordial leads, sometimes you can see that the P wave kind of looks like this. It has a positive and a negative deflection. This is also considered normal. And sometimes it may indicate there is some left atrial enlargement, especially if you get this type of biphasic P wave in the V1, okay? So another important morphology is that it can be P wave can be bifid, okay? Bifid P. Where is it seen? In P mitrale, like in mitral stenosis, right? There is also P pulmonale, where this, P pulmonale, the right atrial enlargement will be more than the left atrial one. So it can have like a morphology like this. So if these are the different variations of the P wave, sometimes the P wave can be entirely negative deflection as well, okay? So if you're getting like, among all these different types of morphology, if you get three distinct types of P morphology in the background of chronic obstructive pulmonary disease, then you can consider the diagnosis of multifocal atrial tachycardia, okay? So hypoxia is the main cause, which is, hypoxia is the main reason why this type of P wave abnormality is going on. And if you correct the hypoxemia, if you correct the COPD, then this will go away. So no need to give any further antiarrhythmic medication here, right? We have discussed about the ventricular tachycardia. This one is a very, very like hot topic for MRCP purpose. So that's why I will just resume back to my board. So write down 3 terms side by side. One is polymorphic VT. Another one is torsades de puentes. This is actually a Spanish originated name. And the other one is long QT syndrome. So all of this have a very, all of this have a very common thing, because the causes are same. Management is same. Long QT, if not treated, can develop into polymorphic VT. Torsades de puentes and polymorphic VT. This is broadly speaking, polymorphic VT has different varieties. Torsades de puentes is as one type of variety. Okay, so there is twisting of the ventricular contraction around the nexus. So it will have like broad complex. You'll see like the VT. This will be broad complex tachycardia, but their morphology will vary. So that's why this is known as the polymorphic VT. As well as after like maybe going like this, you can go like this, something like this. Okay, so this is happening in an irregular nature, and one ventricular contraction will occur around like this type of fibrillatory wave or the axis. Okay, if this is very easy to determine, no need to worry, just Google torsades de puentes, you'll be able to identify it. Important ones are the causes. Okay, so I've just discussed that the causes are very much similar and the management is almost always same. Torsades de puentes management, single most important management is you should give IV Maxol, which is also used in eclampsia patient, right? Okay, next one. So the causes. Okay, so the causes of these conditions are, it can be congenital, it can be drug causes, it can be electrical imbalance. These are the most common causes, not the congenital, the drug causes and the electrical abnormality. And there are some additional causes, I'll discuss them about. So the common congenital causes would be, 2 important causes are important for MRCP purpose. One is the Jarvell-Lange, and the other one is Romano-Ward. So these occur because of some problem with the maybe channels, like different, we have different type of ion channels in our cardiac muscle. So if there is some genetic mutation, this type of congenital abnormalities can take place, and which are prone to developing conditions like polymorphic VT or torsades de puentes or maybe long QT syndrome. So in case of Jarvell-Lange, the common characteristic finding is patients have deafness along with the cardiac conduction abnormality. Okay, but in the Romano-Ward, there is no deafness. So how I used to remember is the term Romano-Ward ends with D, which is why there is no deafness. So what they will do is they will give you these 2 names side by side. They will give you a scenario where they will tell you that the ECG is suggestive of long QT and the patient has no deafness. So which of the causes, congenital causes, can be responsible for this type of manifestation? And the answer would be Romano-Ward. Okay. And the drug causes, most common drug would be, first of all, antibiotic, macrolide antibiotic, most importantly, like erythromycin. So number 2 would be antihistamine, tarfenadine. Number 3 would be actually tricyclic antidepressant or SSRI or antidepressants. Number 4, antipsychotics can also cause this. Anti-malarials can also cause long QT. Number 5 would be antiarrhythmic. Antiarrhythmic drugs, among this, amiodarone, particularly the class 1A antiarrhythmic drugs, amiodarone and sotalol. So these are the particular drugs that can cause polymorphic VT or long QT. Okay, so I'll give you a scenario a bit later on. And among the electrical imbalance, any hypocauses, like for example, hypokalemia, hypocalcemia, hypomagnesemia, hypothermia, they can cause long QT. And additional causes will be ischemic heart disease, myocarditis. Important one is the subarachnoid hemorrhage. Okay, so these are the important causes for long QT or polymorphic VT. What they usually do is, instead of hypocalcemia, they can give you the option hypercalcemia, which does cause cardiac arrhythmia, but not the long QT. Okay, so be very careful. So instead of hypokalemia or hypomagnesemia, they might give you hypophosphatemia, which does not cause long QT. So you should be very careful. And I'll give you a scenario, okay? So a 28-year-old male presented to the emergency department with sudden onset palpitation. On query, he gave history of some cold flu for which he was treated with terfenadine and erythromycin. So what's the possible ECG abnormality that you can expect in this patient? Polymorphic VT or long QT syndrome, right? Okay. So both of these drugs can cause this type of problem. I'll just take like a 2-minute break for the azan, okay? Okay, I had to take a small break for our azan here. So I hope you guys have the energy now. All right, so the bradycardia management, actually bradycardia is more dangerous compared to the tachycardias. And adverse signs are as usual. If the patient is hemodynamically unstable, has previous ischemic heart disease or some sort of heart failure, the patient has lost his consciousness, like syncope or cardiac syncope, and shock features like low BP, patient has turned pale, there is profuse sweating, the hands have turned cold, clammy, and confusion or impaired consciousness. These are all the adverse signs for any arrhythmia, actually. So what are the potential risks of asystole when a person with bradycardia feature can develop pulseless electrical activity or asystole? So for example, complete heart block with broad complex QRS, that is one. Number two, if there is a recent asystole, it can cause another asystole, okay? So that's another important risk factor. And number three is Mobitz type 2 AV block. AV blocks are in general very bad, and especially the type 2, which is known as the Wenke-Back phenomenon. So that's particularly even worse. And ventricular pause, if you do the Holter monitoring and if you're seeing that the ventricular pause is more than 3 seconds, so that's a very bad sign, okay? So all this type of cardiac arrhythmia can actually lead towards asystole or pulseless electrical activity. So in that manner, what we can do, I have discussed, like if you cannot go for immediate intervention, you should go for atropine at least, okay? Because there is indication of atropine till a patient turns asystole. So, okay, so if you're getting feeble pulse, if the patient is having bradycardia, if you cannot go for the pacemaker insertion, you're working in a district general hospital, then you should consider some medical management for this patient so that the patient does not develop cardiac arrest, okay? So that's your ultimate goal. So what you can do is you can give atropine to the patient and the maximum dose can be given up to 3 milligrams. And then you can also consider some inotropic agents like NORAD infusion, as well as in our country, this is commonly practiced. It is also available in the Upajala Health Complex or the district hospitals, that is isoprenaline. Isoprenaline is actually, I think, cheaper. So that's why the government has made it quite available in our country. So isoprenaline, atropine, NORAD, these are the medical or pharmacological interventions that you can give in a patient with feeble pulse or bradycardic pulse who have increased chance of developing into cardiac asystole. But if you're working in a tertiary care hospital, if you're working among the cardiologists, if the patient can be referred as soon as possible to a higher center, go for intervention. What's the intervention? Go for permanent pacemaker insertion. If you do not get to do the permanent pacemaker and the patient is having symptom, go for the temporary pacemaker. So the temporary pacing can be done either transvenous procedure. If you cannot go through the transvenous procedure, go for the transcutaneous procedure, okay? No need to go through details. Just remember these words. Okay, so what are the indications of temporary pacemaker? So all the indication for permanent pacemaker will be very much similar to the temporary pacemaker. Temporary pacemaker is just done to buy the time before we do the permanent pacemaker, okay? So the indications are kind of same. What are the indications? I try to make it as simplified as possible. Number one, severe symptomatic brady. Number two, complete heart block, symptomatic. Number three, in older patient, sick sinus. You can write it down by the side of your notebook, it's fine. Number four, you'll see actually because of parasympathetic overdrive, which occurs in case of inferior MI. So in inferior MI, this is in close proximity to the vagal nerve. And because of the inferior myocardial infarction, there is possibility of vagal inhibition. So that's why bradycardia is more common in inferior MI. We know that, right? But bradycardia in inferior MI is actually reversible. If you treat the MI and if there is well vascularization, reestablishment of the vascularization, so the bradycardia will actually go back to normal. But when the bradycardia is dangerous, when there is anterior MI causing bradycardia or anterior MI causing complete heart block or Mobitz type 2 heart block. So in case of post anterior MI, the patient is having either CHB or type 2 heart block. So these are the important indication for temporary or permanent pacemaker. There are some other indication, for example, drug-resistant tachyarrhythmia. But I'm just writing it for discussion purpose. You don't have to remember it for the exam purpose. And number 6 is during cardiac surgery. This one is important. During cardiac surgery, like especially when you're doing the aortic valve replacement procedure, or the procedures that require you to pass the wire, which might have a possibility of poking through the atrioventricular node. Okay, so these are the like ASD repair or atrial valve, any operation requiring involving the atrial valve operation, or maybe the intraatrial septum, any procedure that can poke the AV node, that in that procedures, this type of pacemaker, temporary or permanent pacemaker, can be done. Remember, during cardiac surgery. So these are the indications for temporary or permanent pacemaker. Now, what are the common complications? Okay, so I'll ask anybody from the online participant, have you ever seen pacemaker patients who had pacemaker inserted? Have you ever seen?
Yes, ma'am. Yes, ma'am.
Okay, where exactly is the battery located?
Battery located or in the chest, you're asking?
Yes, in the chest, where the device.
Right side. Right side.
Right, left. Yes, fine. What's the position?
It's superior lateral. How do I say?
Basically,
straight,
infraclavicular.
Yeah, infraclavicular, right? Yeah.
Infraclavicular. Okay, yes,
Yeah.
that's very good. And what's the commonest complication that can happen during a pacemaker insertion? Do you have any idea?
Ma'am, when the patient maybe does excessive hand movement, right-sided hand movement mostly, that might affect the pacemaker.
Very good. That's something that occurs after you insert the pacemaker.
Yeah.
But during the pacemaker, what's the commonest
No,
complication that might arise?
No idea.
Okay, no problem. So commonest complication is actually injury to the lung causing pneumothorax, okay? So I think these are the things that are not discussed in the book. So maybe if you just, I'll try to like explain just the gist of the pacemaker so that you guys can actually remember. This will be helpful in the part 2 written examination as well. So pacemaker site, first of all, you can even tell from the outside, they will usually have, this is situated in the device, or the battery is placed just underneath the subcutaneous tissue. And this is placed right underneath the infraclavicular space, number 1. Number 2, during the pacemaker insertion, what can happen is there might be development of pneumothorax. So it's very important to do a chest x-ray right after the pacemaker insertion, okay? Chest x-ray PA view. And one of the immediate post-op complication can be infection. And the pacemaker infection is very, very difficult to treat with, because this is a foreign body. And until and unless you're removing that foreign body from your body, it will be very hard to treat the infection. So that's why you have to be very cautious with a patient with pacemaker. Do not handle the pacemaker inserted patient frequently. Involve the infectious disease department or microbiologist in the management of the pacemaker patients, and do take daily swab from the pacemaker inserted area. Check for the local signs of infection, inflammation, raised body temperature. Very important to do that, okay? This is how you follow up a patient with pacemaker. And what are the remote complications that can happen? This is particularly very important for PACES exam. In our exam, we often encounter pacemaker complication patients. Most likely, we do not have the acute cases, okay? Because of course, unstable patient who has developed pneumothorax, this will not be given in the exam setting. And infectious patient, these are very toxic, so they do not want the exam candidates to handle this type of patients. So they usually pick up the remote complications that can happen following a pacemaker insertion. So one is pacemaker syndrome. I can give you the mechanism of how the pacemaker syndrome works, but that is a bit complicated. So I'll just tell you, like after a couple of years, you have inserted a pacemaker to a patient, and now the patient is complaining of shortness of breath, dizziness, has leg swelling or features of heart failure. So you should consider whether pacemaker syndrome is taking place or not, okay? Have high clinical suspicion of pacemaker syndrome rather than heart failure. Pacemaker syndrome eventually causes heart failure, but the device itself, if the device itself is causing heart failure, you should try to consider like CRTD and removal of the pacemaker. And it also happens because of the single atrial chamber pacemakers, okay? So treatment is actually dual chamber. But if for the part 1 examination, you don't want to remember this, that's fine. So just remember that the immediate complication or the first complication during the procedure can happen is the pneumothorax. So chest X-ray is very important. Immediate or post-op complication is important, that is infection. So culture, swab, these are important from the site of the pacemaker. And remote complication, just remember the name, that is pacemaker syndrome. And treatment is dual chamber pacemaker. And of course, there might be lead displacement or the battery displacement, and the battery eventually dies out after 10 years. So you should consider these also. And if there is some sort of displacement, the first investigation that you can do is do an ECG, at the same time do an X-ray, okay? I will not really jibber jabber anymore regarding the pacemaker. Just remember that in ECG, for part 2 written, I will try to draw one. Okay, so look for the spikes. Okay, so for example, this is the P wave, this is Q, this is R. Imagine this is a normal rhythm, okay? So in case of pacemaker, there is usually this type of very sharp and very vertical and straight line, like the English letter I, will be right before the ventricular pacing, okay? So, and that's one. And usually, if the patient is having successful pacemaker, right after this pacemaker spike, there will be a broad complex. Usually the QRS duration is broad, okay? So it's not pathological, it's actually physiological. And this ventricular contraction occurs because of the external pacing. That is why it takes more time to depolarize, which is why you're having wide QRS complex right after a pacemaker spike. So this is a normal variant, okay? Just remember this. We usually read about the difference between the single atrial pacing versus dual pacing. This is not that important for MRCP. Okay. All right, so does anybody have any questions?
Yeah.
Sorry, yes. Go on.
I have a question. Ma'am, is there any restriction to number of how many times we can place a temporary pacemaker to the patient?
Is there any restriction of what?
How many times can we insert the pacemaker, temporary pacemaker to the patient? Like maybe once or twice can be done, or it can be done n number of times.
If there is complication related to the pacemaker, you can change it. And although because of these are invasive procedure, so it actually varies from one person to another, and the decision is actually taken by the consultant. But there, I don't really think that there is a specific number of the times you can change the pacemaker. But imagine yourself as the patient, and instead of going through repeated procedure, you would actually like your pacemaker to work properly for 10 years without having any complication, right? So that's the exact same way. I don't really think that there is any straight cut number, but the ballparking number would be two times.
Okay, thank you.
Okay. All right, our next topic, let's see. Okay, why is this not working? pacemaker, we've discussed about the atrial fibrillation. So this is actually the last topic for cardiac arrhythmia, and atrial fibrillation, this has been a very hot topic or favorite topic from our 5th year of teaching, okay? So what are the causes? What are some of the causes of atrial fibrillation? Dr. Abu Taslim, can you unmute yourself and tell me what are the causes, some important causes of atrial fibrillation? Okay, no problem. Dr. Anupam Bishwas, can you unmute yourself and tell me?
I don't know actually.
Yes, any causes for atrial fibrillation? Hello, can you hear me?
Yes, very.
Oh, okay. Anything that comes in your mind?
I don't know.
Trust me, with atrial fibrillation, there is no wrong answer because
High BP, high blood pressure,
high blood pressure, exactly. And Dr.
atherosclerosis.
Yes, Dr. Anupam, can you add one cause? Anything? Okay, maybe you're having some technical difficulties, no worries. Dr. Kobir, can you tell me some more causes? Thyrotoxicosis is very good, very important. Doctor, yes? Valvular heart disease, very good. Which valvular heart disease are more? Mitral valvular heart disease, very good. Dr. Deep?
Heart failure.
Heart failure, yes.
Cardiomyopathy.
Cardiomyopathy, yes, very good. And
Medications.
medications, like, give me one example. Okay, no problem. Anything else apart from the medication? Any non-cardiac causes?
Pericarditis.
Pericarditis, that's a cardiac cause, but very good actually. Thyrotoxicosis, yes. Any other common cause? Frequently, we have seen this in our, sorry?
Pneumonia.
Pneumonia, yes. Very important. Pneumonia can cause atrial fibrillation. And?
Asthma.
Asthma, COPD, yes. Uncontrolled, this can cause atrial fibrillation.
Ma'am, and also poisoning cases we have seen.
Poisoning case, okay, very good. Acute emergency cases. So you see, like there is no literally wrong answer for the causes of atrial fibrillation, because anything and everything, our cardiology respected professor, he told us when he was discussing about the atrial fibrillation, anything and everything can cause atrial fibrillation. And if you come up with one medical condition, and if you go through like maybe 10, 12 days, the list will just keep on going and going, because there is no wrong answer. Any electrical abnormality, any acute alcohol intoxication, any poisoning cases, any injury, chest injury, pneumothorax, any chest infection, any type of cardiomyopathy, heart failure, uncontrolled hypertension, myocardial infarction, thyrotoxicosis, these all, even head injury or subarachnoid hemorrhage, myocarditis, these all can cause, atrial fibrillation. So the causes of atrial fibrillation is very varied and it has no boundary. So what's the ECG finding? Can you tell me, Dr. Kobir, can you tell me? Absence of P wave, yes, very good. And?
Irregular rhythm.
Irregular rhythm, very good. Anything else? How will the QRS complex look like? What will be the duration? Narrow complex, right? Narrow complex, exactly. These are the three important features, okay? Loss of P wave, irregular, and narrow complex. It can be, if it is fast ventricular response or FVR, then there can be tachycardia. And if it is slow ventricular response, then it can be like bradycardic feature, okay? So the rate is not
the rhythm will be irregularly irregular.
Irregularly irregular or irregular, that either answer is fine. Okay, all right. So that we have gone through the causes of the atrial fibrillation. We have gone through the ECG changes of the atrial fibrillation. Now about the management. Okay, Dr. Deep, can you tell me atrial fibrillation, hemodynamic instability, what's the important thing to do?
Unstable patient.
Unstable patient, exactly.
Then we have to
DC shock, exactly. All right. What are the different types of atrial fibrillation? Dr. Kabir? Yes, very good. 3P. Yes. Permanent, persistent and permanent. Okay.
Permanent.
Can you give me, Dr. Neha, can you give me one example of permanent atrial fibrillation?
Ma'am, I just need to think. Permanent.
Okay, no problem. Valvular heart disease, okay? Valvular heart disease that can cause permanent atrial fibrillation because for this reason, if there is permanent atrial fibrillation, you should not go through the rhythm control strategy because they cannot be cardioverted, but you should look for the rate control strategy, okay? So paroxysmal atrial fibrillation, they will go away spontaneously and they usually last less than 7 days. And the persistent one usually goes for more than 7 days. And with the rhythm control strategy, it can go back to the normal rhythm, okay? Or what are the symptoms? Okay, not that important. We have already gone through this. So management is, what's the single most important complication related to atrial fibrillation? Emboli, exactly, thromboembolism. From atrial fibrillation, stroke or transient ischemic attack can happen. All right, that's fine. So our management will be actually divided into control the rate, control the rhythm, and prevent the risk. So that's our main goal of treatment. So in patients, so there are some risks regarding the rhythm control strategy, okay? So when we try to go make the patient go back to the sinus rhythm, exactly during that time period, that's where the most risk of thromboembolism takes place. When the heart is occurring in an irregular rhythm, this is how the heart is habituated, and now all of a sudden you have cardioverted the patient, okay? And during that twilight zone, that's when the most complications of thromboembolism, that's where the dislodgement of the emboli occur, okay? So you have to be very careful regarding cardioverting this type of patients. So during this period of time, what you can do is you can give the patient anticoagulants. You can give the patient low molecular weight heparin and then consider for the cardioversion, okay? All right, so the rate control drug and rhythm control strategy, okay, there are actually some important factors before we go for the rhythm control strategy. For example, patient is being symptomatic after the rate control, younger patient, less than 65 years of age. Here's a box I'll show you. So if you can see this box, so younger patient, symptomatic, first presentation of atrial fibrillation, low atrial fibrillation and no causes, or there is causes, but that can be correctable, for example, pneumonia or alcohol, okay? And if there is heart failure, congestive cardiac failure, so these are the factors favoring for rhythm control. You should consider, no matter at what time period this patient present with atrial fibrillation, you should consider rhythm control strategy. However, if the patient is aged person, like more than 65 years of age, and if there is history of ischemic heart disease, or in some cardiologists would debate that if there is valvular heart disease, that's when rhythm control strategy is not that important. You should just focus on the rate control strategy. Okay, so what are the drugs? Okay, drugs will be BCD. Try to write it like BCD. B is for beta blocker, C is for calcium channel blocker, and D is for digoxin. And I have discussed this in terms of superiority. So if you can give beta blocker, give beta blocker. If there is contraindication to beta blocker, go to calcium channel blocker. If you cannot give either of this and there are no severe contraindication to digoxin, go for the digoxin for the rate control, okay? And the rhythm control strategy, this is a slightly complicated, but I will try to make this simplified. So in terms of rhythm control, try to look at the time period, time frame. So whether the patient presents to you with less than 48-hour time frame or more than 48-hour time frame, okay? So if it is less than 48-hour time frame and you are sure of this, like from the onset of the symptom, and the patient has presented with you to you within this 48-hour time zone, then you can go for the electrical or the chemical cardioversion. But before that, you should give the patient low molecular weight heparin. Then go for the DC shock or maybe chemical cardioversion. By chemical cardioversion, I do mean amiodarone. And there are some medications for the rhythm control, like amiodarone and flecainide. You don't have to remember the other drugs. And if there is some structural heart disease, then do not go for the flecainide, go for the amiodarone. So amiodarone is always the safer and the superior option. And after the patient has been restored to his or her sinus rhythm, no need to further give any anticoagulation, no anticoagulation. So if the patient is young patient, less than 65, patient has symptomatic atrial fibrillation, and there are some reversible causes, or this is a case of idiopathic or lone atrial fibrillation, maybe on the echocardiogram shows that the patient has some sort of congestive cardiac failure, so you should go for the rhythm control strategy, okay? So rhythm control can be done by chemical and electrical. Electrical is done by DC shock, chemical is done by amiodarone and flecainide. If there is structural heart disease, do not give flecainide, go for amiodarone, okay? So far, so clear? Okay. If the patient has presented to you within 48-hour time period, and you're sure that this patient has presented to me from the onset of the symptom to me, and there has been a time lag of 48 hours. I have the time period, so give the patient low molecular weight heparin to prevent the risk of thromboembolism, and then give DC shock or chemical cardioversion chosen by the cardiologist. But you're thinking of going for the elective cardioversion, okay? And if the patient has presented to you after 48 hours, so that's when, if you're going for the elective procedure, give the patient 3 weeks of anticoagulation, okay? And then give the patient a date for DC shock or maybe chemical cardioversion, whatsoever, and keep the patient anticoagulated for 4 weeks. Is it clear? Now, when you go back to your home today, and if you go through the management of atrial fibrillation, you'll see more or less all the information that is given to you in that book is very much similar to what I've just said. Okay, this is the basic gist of the management of atrial fibrillation. And if there is a treatable or correctable cause, focus on that rather than going for any sort of cardioversion, okay? Because that puts the patient in developing without treating the underlying cause. If you go for the cardioversion, you will be doing more harm than good. For example, the patient has pneumonia with atrial fibrillation. Would you like to give patient presented to you with within 24-hour period of time? What's the treatment option? Pneumonia patient, atrial fibrillation, presented within 36 hours, maybe. How would you like to treat this patient atrial fibrillation? Rhythm control strategy, but there is a reversible cause, that's the pneumonia. So give the patient antibiotic, okay? Do you see my point now? All right. Okay. Cardioversion, onset, 48-hour. Okay, pharmacological, discussed about this. Okay, and then reducing, we have discussed about the rate control strategy, rhythm control strategy, now about the stroke risk prevention, okay? You should go for the CHAD-2 scoring, and there will be tons of questions from the stroke risk assessment. And you should always do the scoring in your mind. Like first look at the age, look at the sex, look whether the patient has some sort of comorbidity. So the C here stands for the congestive heart failure, H is hypertension, A is for age. If the age is more than 75, you'll get 2 points. If the age is within 65 to 74, there is 1 point. And the D is for diabetes, S is for stroke or transient ischemic attack, so that will be 2 points. V is basically, you can see vascular disease. It could be peripheral artery disease or ischemic heart disease. A is just to remember it by. S is for sex, for female sex, it's more dangerous. So 0, no treatment. 1, for the male, consider anticoagulation. This is a gray area. And for female, there is no treatment because for the female sex, they're getting 1 point. And if the score is 2 or more, then definite indication of anticoagulation, and this should be considered lifelong. Okay, so a lot of people have debate regarding the one score with the male. Okay, so they might consider, some consider aspirin, some consider warfarin, depends on the risk versus benefit ratio actually. Okay, so can anybody tell me what are the absolute contraindication for anticoagulation? Bleeding disorder. Okay, fine, that's good. Dr. Dev, can you tell me?
Hemorrhagic stroke.
Very good. Hemorrhagic stroke, absolute contraindication. Dr. Neha, can you tell me one contraindication of anticoagulation?
Trauma.
Head trauma. Okay, fine, that's good. Any other complication you'd like to add? Sorry, contraindication?
Active bleeding, coagulopathy.
Yes, bleeding coagulopathy, that has been discussed. Dr. Kobir, another one? You should not give anticoagulation if the patient has even ischemic stroke also, because within 6 months time period is also, like risky. Okay, another one is, I think for the hemorrhagic stroke, it's 6-month period, and for the ischemic stroke, it's 2 months. I'm not sure. I have to go through the book. But remember, like any stroke, any recent episodes of head injury or trauma or any surgery, like brain surgery, if there is bleeding disorder, any coagulopathies, if there is uncontrolled hypertension, okay, like the high blood pressure more than 180 by 110, so that's also a contraindication. If there has been any recent surgery, even in the abdomen, okay, like if there is any bleeding peptic ulcer disease and you have gone for the duodenal perforation operation, you cannot go for the anticoagulation. So before considering any type of anticoagulation, you should consider these absolute contraindication. All right, even pregnancy is actually a contraindication also. Warfarin, does warfarin have any teratogenic effect during pregnancy? Okay. And some people with genetically susceptible people, this is a very USMLE hot topic. So this question is for you. Warfarin has given to a patient, and within minutes, the patient has developed gangrene, digital gangrene and skin necrosis. What is this called? Warfarin-induced myonecrosis. Exactly. So have you ever seen this type of patient? I have seen a patient who lost her entire ankle, like entire feet, because of this. This patient is actually staying in the PG hospital in the internal medicine department. She has several, blackish gangrene finger. She lost her entire right foot because of this. And there's huge ecchymosis all over her body because of this warfarin. This is so like a very bad situation, actually. Okay, so dabigatran. Why all of a sudden dabigatran? Oh, because I think because of the anticoagulation. Okay, so this box is quite important because it will give you the main mechanism of action, like heparin activates the antithrombin 3, thereby neutralizes the activator factor 10. Clopidogrel is basically inhibits the ADP to bind to the ADP receptor to bind to the platelet and thereby prevents platelet aggregation. Abciximab causes, it's a glycoprotein 2B3 receptor. Just go through the mechanism of action, okay? Like this is very undergrad level situation here. Maybe go through the dabigatran indication as well. One of the important indication is DVT. In DVT patient, we do give DOAC or NOAC, okay? So I think in the recent guideline, instead of using low molecular weight heparin for 5 to 7 days and then switching to the warfarin, and then depending on the INR and as well as the number of episodes, now NHS has given a very straight cut guideline, like you do not have to go through this dilemma, just go for DOAC or NOAC, okay? Direct oral anticoagulant agents. Okay, side effects are hemorrhage, but that's relatively less compared to warfarin. Drug safety, okay. But then again, like for patients with valvular replacement, warfarin still remains the drug of choice, okay? Because you can monitor the warfarin, Of course, the drugs or the drugs, they do not really require any frequent monitoring like the warfarin. But however, in case of valve replacement patient, it's very important to do so. So you can just, like give the PT and INR to the patient and just adjust warfarin accordingly. So that's why we give INR book, like in the advanced countries, they give a yellow book which contains their INR record. And that's why it's easier to monitor their INR. So in valve replacement patient, there is still indication of warfarin. Okay, atrial flutter. The reason why I actually did not talk about atrial flutter before, because it's kind of like a very, I think this can be cute type of arrhythmia. At the same time, this is like one of those, has anybody seen Moana, the movie by the Disney? So the Moana fights off with a villain that looks like a very coconut type of villain. They're very sweet and cute looking. They're very small, but once they start fighting, they have like very sharp fangs. So atrial flutter is kind of like that. So if untreated, this can be very serious. So I will show you the picture. I have that. Okay, this one is actually ventricular fibrillation, not the atrial flutter. But you see, like this is very like in our country, we have a term like hijibiji. So if you see any hijibiji or scribbles on the ECG paper, think of it might be ventricular fibrillation, like in this here, or the sawtooth appearance. This looks very much similar, but it will actually be like this. Okay, so this will look very similar, the atrial flutter and the, but atrial flutter occurs in regular interval because I couldn't draw it. So atrial flutters will be occurring in regular interval and the ventricular fibrillation will be entirely irregular. Okay. So just remember, like the ECG finding, sawtooth appearance is the characteristic finding, and the atria will be contracting in a higher rate compared to the ventricle. There will be atrial contraction and ventricular contraction mismatch. So if the atrium is contracting at the rate of 300, the ventricle will actually occur in a half dose, like it will act in a 150 beats per minute way. Maybe visible after carotid sinus massage. Okay, similar. Important treatment is radio frequency ablation. This is the important treatment. Okay, Wolff-Parkinson syndrome, ECG characteristic finding. This is, of course, this is a congenital accessory conducting pathway. And there are several cardiac arrhythmia that can occur with the Wolff-Parkinson White syndrome. Two most common would be AVRT, atrioventricular reentrant tachycardia, or the atrioventricular nodal reentrant tachycardia. So previously I have drawn a picture. I'll draw it again, no worries. So in case of atrioventricular reentrant tachycardia, basically, there will be an accessory pathway, okay? So maybe this is the accessory pathway. So in the accessory pathway, the generated impulses coming from the SA node can go back towards the atrium. So this is the reentrant tachycardia. And if it bypasses the node, the AV node, and goes back to the atrium, then that is known as the AVNRT, simplified way, okay? No need to consider like the orthodromic or the antidromic pathways and whatsoever. You don't have to make your life more complicated, okay? There are too many things to read. So just remember the important arrhythmias are the AVRT and the AVNRT, and also atrial fibrillation and ventricular fibrillation, or even sinus pauses can also occur in. Don't remember this, just remember these four, okay? These can happen in the WPW syndrome. Now on the ECG, or what you can see, if you, there are so many causes behind prolonged PR interval or the first degree AV block, but if you get short PR interval, there is only one cause that is WPW, okay? So the PR interval is usually 0.1 to 0.20 second. So maybe 3 to 5 small square. This is the normal duration, okay? So if this is less than 3 small square, then this is a short PR interval. And there is only one indication for short PR interval, and that is WPW. The reason why I'm talking so much about this is because I actually had WPW type B ECG in my MRCP Part 2 written examination. And another characteristic finding is there is delta wave. What is the delta wave? This is P, this is Q, and this is sloping. See, this is the sloping. And now this is the T wave. So QRS complex, there will be a sloping, upward sloping. So this is known as the delta wave. There are actually two different types. When the accessory pathway is happening in the right side and the left side. So depending on that, there is WPW type A and type B, and type B is more common in the type A. So when the pathway is on the right side, there will be left axis deviation. And if the pathway is on the left side, there is right axis deviation. Very theoretical. Important treatment is radiofrequency ablation. So you need to, with using the radiofrequency, you need to ablate that accessory pathway. Okay, but if you go for the radiofrequency ablation, this is the tricky scenario. There is often some scar tissue formation, okay, because of the radiofrequency, and scar tissue is always responsible for considering another type of arrhythmia. Okay, so, but then again, not hypertrophic, like the scar tissue itself can generate different types of cardiac arrhythmia, not necessarily have to be a specific pattern, okay? So this is an abnormal tissue, right? In the myocardium, this is actually an abnormal bundle of tissue. So it can actually produce or impair with the normal conduction pathway. So, but then again, in case of WPW, of course, considering the risk versus benefit ratio, you have to take this risk, right? So you have to ablate this accessory pathway. So there is one saying, like with any autoimmune condition, there is association of another autoimmune condition. Like, for example, if a patient has rheumatoid arthritis, that patient might have higher chances of having Addison disease, celiac disease, or even pernicious anemia. Just like that, if there is some sort of congenital abnormality, then there is more chance of having another type of congenital abnormality. Like in case of WPW, you can expect HOCM, mitral valve prolapse, Epstein anomaly. However, thyrotoxicosis is a non-cardiac thing, but this has higher chances of association to be with WPW and ASD secondum, okay? Definitive treatment, radiofrequency ablation. There are some medical therapies as well, antiarrhythmic drugs. Okay, all right. Long QT, we have discussed about this before. Here, they're talking about different features of long QT, like long QT1 is exertional. Try to like highlight this particular one. Exertional. Okay. Long QT2, this one is after emotional stress, exercise, or even auditory stimuli. So it has slightly bizarre forms of triggers. Long QT3, this is the most deadliest one, can even occur at night or at rest. And there is a variety of the long QT which can cause without any causing long QT or whatsoever. It can actually present in one way, that is the death, okay? So treatment is basically avoid the triggers, like we have discussed. For example, avoid the drugs that can cause long QT. Like, give me the name of the antibiotic, Dr. Kabir. Erythromycin, very good. Any medication you would like to add on to that? Tarfenadine or antihistamine. Okay, Dr. Neha, can you tell me one medication that can cause long QT? Dr. Neha, are you there? Okay, all right, I'll ask her something else. Dr. Deep, one medication that can cause long QT?
TCA.
Tricyclic antidepressant, very good. And which antiarrhythmic drug can cause long QT? Amiodarone, sotalol, exactly, very good. And name one electrical abnormality or imbalance that can cause? Yes, and hypercalcemia, very good. And any non-cardiac cause that you'd like to consider from the miscellaneous causes? Subarachnoid hemorrhage, yes, very good, excellent. So, okay, these are the treatment options. Implantable cardiac defibrillator. Most of the genetic or congenital conduction abnormality like LOQ-QT, HOCM, Brugada, and if there is previous cardiac arrest due to VT or VF, and this indication is a bit difficult to remember, but you can remember like after post-MI, and you do a post-MI patient for the risk stratification, we go for the ETT. And on the ETT or the exercise tolerance test, if you see non-sustained VT or inducible VT in an EPS, okay, and there is ejection fraction less than 35%, so we can go for the implantable cardiac defibrillator. Basically, if there is a previous involvement of ventricular tachycardia, so in order to prevent a further ventricular tachycardia or ventricular fibrillation, we can go for the implantable cardiac defibrillator. Okay, so far we are actually done with the cardiac arrhythmia portion. And I don't think that I will be able to cover the rest of the... So far, do you have any question for me? Cardiac arrhythmia. No need to worry about whether I'll be able to discuss the ischemic heart disease today or not, because if I'm not able to do, no problem. We still have 2 more classes. We can combine that in the next class also. So any question for me at this stage in the from the cardiac arrhythmia section? Okay, all right. So in that case, I will discuss some questions with you guys. Okay, I hope you guys have the book as well with you. Okay, so that's page number 139. Question number 132. So Dr. Kobir, can you read out the question for me? Read out the question.
A 66-year-old lady presented to the emergency department with a 5-minute history of right upper limb weakness, with which simultaneously resolved. She had a past medical history of hypertension, for which she is taking amlodipine 10 mg once daily. She is not diabetic. She currently smokes 10 cigarettes a day. Her examination was reported for an irregular heartbeat.
Okay.
Electrocardiogram confirms a diagnosis of atrial fibrillation. CT data showed no evidence of intracranial hemorrhage. Is otherwise well with a normal renal function.
So what's the question?
What is the most appropriate next step?
Okay, before you read out the answer, what I would like for the people on the online as well as other candidates as well, what does the question say from the STEM? First of all, age, 66 years of age. So you might get 1 point because this is within the range of 65 to 74 years in the CHADVA score, right? Okay, number 2, that's a lady. So already there is 1 score. And the next STEM reveals that 5-minute history of right upper limb weakness. So that means transient ischemic attack. So already you have, that's 2 scores. So 2, 1, 1. So that's already 4, score 4. Do you need to go through the rest of the STEM to give the answer? So this is the trick, you know, like in the exam scenario, sometimes you may not have the luxury to go through the entire STEM. You just go through the options first, read out the question, and then look at the question STEM. And if you get the relevant, important information in the first bit, do not waste your time reading through the entire STEM. But this is for the exam setting only. This is not when you practice yourself, okay? So now tell me from the options, which one is the right answer? So to read out the option.
Option A, refer to anticoagulant training. Option B, start 300 mg aspirin and discharge home. Option C, non-urgent referral to the ischemic training. Option D, commence the patient on resolution. Option A, refer the patient to psychiatry.
Okay, so what's your answer? Patient has score 4. Very good, exactly. Because we know that when the score is 2 already, there is indication of starting anticoagulation. Okay, that's very good. So that means that you guys have been paying attention to my class. I thank you. Okay, so the next question is for Dr. Deep. Okay, so go through the page 141. This is the page number 141. And
page number is a bit different. Can I have the question?
Okay, yeah, the question number is 138.
In my book, it's 280. I don't know why.
Okay, no problem. Is the question like 71-year-old
Yeah.
woman? Okay, read the question out for me.
Yeah, 71-year-old woman presents with palpitation and lightheadedness. An ECG shows that she is in atrial fibrillation with a rate of 130 per minute. Our blood pressure is normal and examination of our cardiorespiratory system is otherwise unremarkable. Our past medical history includes well-controlled asthma on salbutamol and beclomethasone and depression on citalopram. Her symptoms have been present for around 3 days. What is the most appropriate medication to use for rate control?
So what they're demanding is rate control, not rhythm control, because the patient is already more than 65 years of age. So we will focus on the rate control strategy. Okay. Now, what have you got from the STEM?
She has asthma, well-controlled asthma, and depression.
Okay. And now go through the options. So what are the options?
Diltiazem, sotalol, digoxin, atenolol, amiodarone.
Okay. So which medication would you like to consider for the rate control? So what's your final answer? Very good, because why are you confused? Diltiazem is a calcium channel blocker, right? Rate limiting calcium channel blocker. And with the, you cannot give her sotalol or atenolol because she has poorly controlled asthma. And digoxin is the least favorite one. And amiodarone is for rhythm control strategy, which we're not going for. Was the option that is left? Of course, the diltiazem. All right, very good, Dr. Deep. So Dr. Neha, are you there?
Yes, ma'am. My phone had got hanged that time. I could not unmute myself.
Okay, no problem. So is it okay with you now?
Yeah, ma'am.
Okay. So do you have the book with you?
No, ma'am.
Do you have the online copy of it?
I don't have right now, ma'am. I'll have to find that.
They haven't provided you with the copy yet?
I guess they have, but I haven't downloaded yet.
Okay. You should, okay? Because most of the time when we're discussing in our class, we try to go through some of the difficult questions, okay? That can be a bit hard for you to solve by your own. Okay, so I'll read out the question for you. So I'll just have the atrial fibrillation I will ask you. Okay. Okay, a 70-year-old man presented to the emergency department following a fall and head injury. Okay, this is his third fall in the past 12 months. He has a background of persistent atrial fibrillation, type 2 diabetes, and Parkinson's disease. He is taking tablet apixaban 5 mg twice daily, bisoprolol 5 mg once daily, levodopa 100 mg 4 times a day, and tablet metformin 1 mg BD. CT scan of the head reveals no acute finding. So what is the most appropriate management regarding his anticoagulation? Have you got the scenario?
Yes, ma'am.
Okay, so basically they want you to think about the anticoagulation strategy in a patient who's elderly. He's 70 years of age. Recently, he has presented to the emergency department with fall and head injury, but the CT scan does not reveal any finding. So there is no bleeding or ischemic stroke or anything like that. And patient is already having persistent atrial fibrillation, some comorbidities like type 2 diabetes and Parkinson. And he's taking apixaban for atrial fibrillation and bisoprolol, as well as levodopa for her Parkinsonism and tablet metformin for her diabetes. So what's the most important management regarding the anticoagulation? Number 1, stop apixaban for now, optimize his Parkinson medication, and consider restarting in 6 months. Number 2, switch to aspirin. Number 3, stop anticoagulation. Number 4, stop apixaban for now, optimize his Parkinson medication, and consider starting warfarin in 6 months. And number 5, continue apixaban.
Oh God, ma'am. I'm good. Just a minute.
Okay, do you want me to go through the options again?
Yes, please.
Okay, number 1, stop apixaban for now, optimize his Parkinson medication, and consider restarting the apixaban 6 months later. Got it?
Okay.
Okay, number 2, switch to aspirin. Number 3,
Oh.
stop anticoagulation.
No, this should not be the answer.
Number 4, stop apixaban for now, optimize his Parkinson medication, and consider starting warfarin in 6 months.
No.
And number 5, continue his current medication. That is, continue apixaban.
Ma'am, I think I would go with the 5th option.
Which one?
Continue apixaban.
Okay, very good. So yes, you should. Well, what's the reason?
Because the patient.
What's the Chadva score of this patient?
Sorry, ma'am. I'll not be
Okay,
able
no
to tell you the score. Yeah.
In the STEM, you can see the age. For the age, he will get 1 point, right? And
Yeah.
then he has comorbidity like diabetes mellitus. That is
Yeah.
0.2. For he's a man, so he will not get a point on the base of his sex. Okay, number 3. Number 3 is no hypertension, no age, no congestive cardiac failure, no stroke, no vascular event. So his Chadva score is basically 2. And if the score is 2 or more, then we should consider anticoagulation. Now, the thing is, he's already receiving anticoagulation in the form of apixaban. All right. And he has a head injury. So we know that in head injury patient, we should not give warfarin. Like we should not go for the strong anticoagulants. So any option, including warfarin, will not be the answer. That's the logical thinking, okay?
Yeah,
the
yeah,
next
right.
logical thinking is he should receive some form of anticoagulation whatsoever because his Chadva score is high. That is 2, okay? So we should not stop the apixaban because compared to the warfarin, apixaban has low tendency of hemorrhage. And number 3 is the reason why we should continue apixaban is because the CT scan does not reveal any bleeding. Just a fall, no matter how many times, the patient might have some joint problem as well. Maybe that's why he's falling. So that is not an indication to stop the anticoagulant, which is an absolute indication for this patient. So it's a very logical, this is how you like construct the logical thinking. So thank you, Dr. Neha, for getting this right.
Thank you, ma'am.
Okay, all right. So I think Dr. Abu Taslim, he has been muted for a very long time. So I think consequently the questions will be go towards you guys. All right, I will ask you number 111. Dr. Kobir. Question number 111.
25-year-old woman is brought to the emergency department by a friend. She developed palpitations around 30 minutes ago while drinking a cup of coffee. Our only past medical history of note is asthma and rheumatism, for which she uses a salbutamol inhaler and takes diazepam acid respectively. The admission shows the supraventricular tachycardia at a rate of 160 beats per minute. Vagal maneuvers are unsuccessful. What is the most appropriate next step in her management?
Okay, so what's the STEM is about? Management of supraventricular tachycardia in the background of asthma. Okay, so you have already done the carotid sinus massage or the vagal maneuvers already. So what's the most appropriate next step? Would read out the options first. Don't worry, read out the option first. For the SVT management. Beta blocker. Okay, you don't have to give me the answer. Go through the options. Read out the options.
Intravenous verapamil, intravenous amiodarone, intravenous adenosine, electrical cardioversion, and intravenous smoothing.
Okay, now think logically. Electrical cardioversion, does the patient need it?
No.
No, the patient is hemodynamically stable. So D is out, okay?
Intravenous verapamil is on.
Why?
Because asthma.
Verapamil, what type of medication is verapamil? Yeah, calcium channel blocker, why would it be contraindicated? You should not go for the beta blocker. You should not go for the adenosine, right? Was the management left here? Verapamil, we have told about this, like vagal maneuver or the carotid sinus massage, adenosine 6, 12, 12, then verapamil for the supraventricular tachycardia, okay? Rate limiting calcium channel blocker. Okay, no problem. But do you see like how you should think about the possibilities in your mind, okay? All right, so as you could not get this one, I will give you another question regarding the SVT, okay? So go through the 100 and number 8, 108. Read out the STEM first.
A 55-year-old presents to the emergency department with 8-hour history of heart palpitation. She has a heart rate of 200 beats per minute and ECG shows regular QRS complex of 0.08 seconds. She has not had a chest pain or episodes of syncope and has no signs of heart failure.
Okay.
Her blood pressure is 130 by 90 millimeter of mercury, and her oxygen saturations are 97% on air.
Okay.
What should you do first?
Okay, before going through the option, what does the STEM tell you? What is it a case of? Regular QRS complex, narrow complex tachycardia, regular. So that's was the diagnosis first. No, irregular is atrial fibrillation. So what's the remaining one? Supraventricular tachycardia. Excellent. Okay, so all the parameters are good. She does not have any asthma whatsoever. But the question is what you should do first. First thing. Okay, now read out the option.
Option A, carotid sinus massage. Option B, adenosine 6 mg. Option C, adenosine 12 mg. Option D, amiodarone 300 mg. Option E, atropine 0.5 mg.
Okay, so which one you should do first? That's your cue. Carotid sinus massage, exactly, because that's the first thing you should do. And then if the patient does not come back to the normal sinus, go for the adenosine 6, 12, 12, and then verapamil. Okay, that's really good. So discuss about this. Okay, Dr. Deep. Okay, now I'll come back to you a bit later on. Dr. Neha Singh, unmute yourself, could you?
Yes, ma'am.
Okay, so I will say this question to you. A 62-year-old man is referred from the emergency department with a pulse 40 beats per minute. So patient is 60 years old. He has been referred from the emergency department. Pulse is bradycardia. Which one of the following factors carries the least risk of asystole when the risk stratifying of the patient? So you should go for not the high risk, go for which has the least risk for the patient to develop cardiac arrest or cardiac asystole. So I will read out the options for you. Number 1, ventricular pause of 5 seconds. Have you got that?
Yeah, got it.
Okay, number 2, recent asystole.
Okay.
Number 3, complete heart block with narrow complex QRS.
Okay.
Number 4, Mobitz type 2 AV block.
Okay.
And number 5 is complete heart block with a broad complex QRS.
Ma'am, either it is complete heart block. I guess it is narrow.
Narrow
Complete
complex
heart block,
QRS, exactly.
narrow complex, yeah.
Yeah, exactly. Because the answer is the least risk, okay?
Yeah.
So all the other options are actually carries high risk of going
Yeah.
into cardiac asystole. Okay, very good, Dr. Neha. So next question is, actually there are too many questions from atrial fibrillation, and I would like to discuss this with you because these can be quite difficult in terms of solving it by yourself. Okay, the next one is, okay, Dr. Deep, it's for you. So read out the question 146.
A 54-year-old male with no past history is found to be in atrial fibrillation during consultation regarding a sprained ankle. He reports no history of palpitation or dyspnea. After discussing treatment options, he elects not to be cardioverted. Examination of the cardiovascular system is otherwise unremarkable with a blood pressure of 118/76 millimeter of mercury. According to the latest NICE guidelines, if the patient remains in chronic atrial fibrillation, what is the most suitable treatment to offer?
Okay, so a patient who is apparently normal, imagine yourself, you have sprained an ankle, and on the routine examination, they have revealed that you have atrial fibrillation. You do not want to be cardioverted in this case. Your hemodynamics are entirely fine. You don't have any ischemic heart disease. You don't have any heart failure features. You don't have diabetes, hypertension. You don't have any stroke. Your age is, you're quite young. You don't have any comorbidities whatsoever. And so what's your CHADVA score here? 0. So read out the treatment options.
The options are no treatment, warfarin, dabigatran, aspirin plus dipyridamole, and aspirin.
Okay.
No treatment is all.
No treatment is the important. Okay, yes, very good. And I'm really glad that you picked it up because previously, even if you scored 0, there was indication of using aspirin. But nowadays, NICE recommends that giving nothing is superior to aspirin because aspirin kind of works in a placebo manner here. Okay, so that's why there is no need for any medication whatsoever. Very good, Dr. Deep. Okay, so next question. Okay, this one is also for you, Dr. Deep. So question number 152.
A 62-year-old female with no past history is admitted to hospital with a left-sided hemiparesis. Examination revealed that she is in atrial fibrillation. CT scan of her brain shows a cerebral infarction. What is the most appropriate anticoagulation strategy for this patient? Options are lifelong warfarin started immediately, aspirin started immediately, switching to lifelong warfarin after 2 weeks. Lifelong aspirin started immediately. Lifelong aspirin started after 2 weeks. 6 months of warfarin started immediately.
Okay.
So immediate warfarin is already I have to take them out. So A and B, the A and E is out.
Okay, very good.
And then comes the aspirin. Started immediately.
What's the score? What's the Chadva score?
62 female, so at least 2 I can see here.
Okay, very good. So 2. So there is a role of anticoagulation, but the patient has recent stroke. What's the logical thinking? What does it say?
Have to use aspirin in some.
Okay,
Yeah.
and then would you like to consider warfarin later on?
So no, not within like recent future.
Okay, fine, very fine. So what's the option do you think sounds most logical?
Yeah, lifelong aspirin started immediately.
So this is actually one of those questions where you're having therapeutic dilemma, okay?
Yeah.
So you know that with the stroke, you should not give the patient anticoagulant, but the patient has absolute indication of anticoagulation later on. So this is not a hemorrhagic stroke. You can start anticoagulation after the patient settles down. So the option is actually B. Start the aspirin immediately and then switch to the lifelong warfarin after 2 weeks, okay? So in the risk versus benefit ratio, in the long term, patient will benefit more from the warfarin. And in the short term, if you give warfarin, that will cause harm. So this is how you measure out the risk versus benefit ratio. Okay, all right. So next question is also for you. 144, question number 144. Dr. Neha, be prepared. The next question is going to be for you. This one is for you, Dr. Deep, 144.
51-year-old female presents to the emergency department following an episode of transient right-sided weakness lasting 10 to 15 minutes. Examination revealed the patient to be in atrial fibrillation. If the patient remains in chronic atrial fibrillation with what is the most suitable form of anticoagulation? Aspirin, warfarin, target INR 2 to 3. No anticoagulation, warfarin, target INR 3 to 4. Warfarin, target INR 2 to 3 for 6 months, then aspirin.
So what's the Chadva score of this patient?
2.
2, exactly. So there is role of anticoagulation here. Okay, so what are the options that you can rule out?
No coagulation should be ruled out. Then INR level of 3 to 4 should be ruled out.
Okay.
So the aspirin, I at least have to think about warfarin.
Yes. So it's either
is not a contraindication for.
Exactly.
Yeah.
So which one is the answer? Do you think?
Warfarin, target INR 2 to 3.
Very good. Yes, that's the answer. So this is how you think logically during your examination. Okay, so Dr. Neha, this question is for you. I will read out the question towards you. A 26-year-old female, are you there?
Yes, ma'am. Yes, ma'am.
Okay, all right. So a 26-year-old female is admitted to the hospital with palpitation. ECG shows shortened PR interval and white QRS complex associated with a slurred upstroke in the lead 2. So can you tell me the diagnosis? Short PR interval, a young woman, short PR interval, and in the ECG, there is a slurred upstroke of the QRS complex seen in the lead 2. So what's the diagnosis?
Is it ventricular tachycardia? Not sure, ma'am.
No. For short PR interval, there is only one cause I have mentioned. And maybe if I draw the ECG, imagine this is the P wave, okay? And this is the Q wave. And this is the R. Okay. So this is, you can see this is slurry. There is slurred upstroke. So what do you think the diagnosis is? Is it a young female patient?
Ma'am, that W syndrome would be Wolf.
WPW, Wolf Parkinson
WP.
White syndrome, exactly.
Yeah.
Very good. So your question is, what's the definitive management of this condition? Number 1, accessory pathway ablation. Number 2, lifelong aspirin. Number 3, AV node ablation. Number 4, lifelong amiodarone. Number 5, permanent pacemaker. Do you want me to go through the options again?
Yeah. Yes, please, ma'am.
Okay. So number 1 is accessory pathway ablation. Number 2, lifelong aspirin. Number 3, AV node ablation. Number D, lifelong amiodarone. And number 5, permanent pacemaker.
Lifelong amiodarone.
Lifelong amiodarone. Okay. The thing is, you should consider the definitive management. So what exactly is the pathophysiology in the
Pacemaker,
WPW
that
syndrome?
pacemaker would be a better option then.
No, the pathophysiology, think about that. Why WPWP syndrome is happening? Because of the congenital accessory pathway in between the SA node and the AV node, okay? So you need to ablate that accessory pathway. That's the definitive treatment.
Yeah.
Is it clear?
Yes, ma'am.
Okay. That's good. No need to be feeling down or anything. This is just a very normal discussion. Okay. So I do have another question for you. Where's the log Q2? Sorry, just give me a second. Parkinson, okay, long QTS, the next one, yes. Okay, so which of the following is the most common underlying mechanism causing prolongation of the QT segment? Okay. Have I discussed about this? So I don't think that you'll be able to get it. The answer is blockage of the potassium channel, okay? So in the long QT syndrome, the main pathophysiology lies in the potassium channel blockage. All right. So when you go through the reading discussion in the book, then you'll be able to get it. Okay. I just wrote it as a part of memorizing question. Doesn't involve much thinking. Okay. This question is for you. You review a 24-year-old woman who has recently been diagnosed as having long QT syndrome. You are discussing the need to avoid certain drugs and other aggravating factors. So which one of the following should be avoided if possible? Number 1, methotrexate. Number 2, sertraline. Number 3, grapefruit juice. Number 4, carbamazepine. And number 5, doxycycline. Which medication should be avoided in long QT syndrome?
Doxycycline. Means maybe.
Doxycycline, well, no, doxycycline is not the answer. What is the other answer?
Could you please repeat the options, ma'am?
Okay, yes, of course. Methotrexate, sertraline, grapefruit juice, carbamazepine, doxycycline.
Ma'am, I'm not able to label it under what section does it fall. Otherwise, I know antibiotics should not antibiotics, then antihistamines, tricyclic antidepressants. These are the drugs. Also, amiodarone and the anti-malarial. These drugs are the main causes for the long QT.
Okay, very good. I'm very happy that you remember the classification. But in question pattern, sometime during the examination, they might not give you the straight cut classification. They can just give you the generic name. Okay. So Dr. Kobe, can you tell me which one? Sertraline, exactly, because this is an SSRI, right? So sertralins are not indicated in long QT. And about doxycycline, this is actually a relatively safer drug because among all the macrolides, doxycycline is considered to be not causing any long QT syndrome. So erythromycin is actually the culprit drug. Okay. Dr. Kobir. Okay, so read out the question number 165.
Euphoria or given with a background of osteoporosis is given an inhibition of claviculated with Tourette. A week later, she presents to her young practitioner complaining of paresthesia. On examination, she has hyperlipidemia and spasm.
Okay.
Given the incorrect abnormality, she is likely to have developed what abnormalities is most associated with this.
So what does the stem say? This patient is having osteoporosis, receiving bisphosphonate, and later the presence to the GP. Hypocalcemia, yes, exactly, because carpopedal spasm and hyperreflexia, this can occur in hypocalcemia. So the electrical abnormality that can occur in DCG is long QT syndrome related to the hypercalcemia. Very good. Okay, this is maybe the last question. So this is actually an open question. Anybody can take it. Who can come up with the answer first is fine with me. All right. Okay, this is a rather bit like a big question. So question number 130. Somebody please read it out for me. And then I will talk about the gist of the question, and then you'll be able to come up with the answer.
You are the medical senior health officer on a call in a busy tertiary hospital. It is 2 a.m. and you get called to see a 75-year-old gentleman on the coronary care in the CCU. The nursing staff tell you that 2 days ago, he underwent percutaneous coronary intervention with two drug-eluting stents to the right coronary artery. He was admitted to CCU for monitoring following the procedure as he had an earlier episode of ventricular tachycardia. Your review is you review his admission ECG, which shows ST segment elevation in leads 2-3 ABF. Currently, he is alert with no chest pain and is comfortable at rest. However, his cardiac monitor shows that his observations are heart rate 28 per minute, blood pressure 83/65 millimeter of mercury, respiratory rate is 18 per minute with oxygen saturation 94% on 1 liter of nasal cannula. Both his ECG, which was done shortly before you arrived, and the tracing on the cardiac monitor shows no association between P and QRS-OFs. His QRS rate on ECG is 120 milliseconds. Which of the following is the most appropriate management for this patient? The options are a trial of atropine and isoprenoline with a view to permanent.
So, okay, I would like to interrupt you here at this point. So basically this question is regarding, you're working in a tertiary care hospital. You do have access to do different types of intervention. If you want to, you can refer the patient as well. Okay. Now, secondly, the important information is the patient is an old person who has had inferior MI, lead 2-3 AVF, ST segment elevated STMI. Okay, so this patient has done a coronary intervention, or PCI was done to him with drug-eluting stent. Okay, And now he has no symptom. However, you go through the observation chart, you see that the patient is bradycardic. There is still pulse present, but bradycardia, hypotension, respiratory rate is fine, saturation is borderline-ish, fine. 94% on 1 liter by oxygen, that's fine. Okay, you do the ECG, and you see that there is no association between the P wave and the QRS. So that basically means that there is complete heart block. Okay, all right. So what's the most appropriate management plan? Most appropriate. And I would like to reiterate here, just because you are working in a tertiary care hospital and you have the chance to do the coronary intervention does not mean that you should. Okay, now go through the options.
Trial of atropine and isoprenoline with a view to permanent pacing if sinus rhythm has not been restored by day 5. Immediate pacing with a temporary wear until permanent pacing can be put in place. A trial of atropine and isoprenoline. Continue monitoring only as he is asymptomatic. Immediate pacing with a temporary pacing where that can then be removed / discontinues if the patient stabilizes.
Okay, this is actually one of those scenarios where very specialist type of decision is required. However, this is an exam purpose. So first of all, what they want you to think of, go for some pharmacological intervention. And then later on, when the sinus rhythm has restored, consider permanent pacemaker. But this is a case of inferior MI. Okay, so the patient will actually, with subsequent, the patient has just undergone the paracarditis intervention. So with the revascularization, likely he will come back to his normal sinus rhythm whatsoever. Okay, so we can immediately consider whatever options are having the intervention, we can rule them out. So A is out, B is out, okay, E is also out because we are not going for any intervention here. So the only option that is remaining is the C and D. So C is trial of atropine and isoprenoline. You can give this medication, or you just continue monitoring this patient. That's the decision, right? Do you agree with me or not? Okay, so which one do you think is the most rational thing to do?
Continue monitoring.
Continue monitoring, but here is the twisted bit, okay? The patient is bradycardia, asymptomatic bradycardia, so there is no need for permanent pacemaker or any temporary pacing, okay? But patient does have comorbidities. The patient has bradycardia, although asymptomatic, and the patient is having complete heart block with normal QRS complex. So with normal QRS complex, the patient is less chance of going through the asystole. However, this is not a narrow complex, so it is not entirely safe. So that's why you should give the patient some medication. It's actually a bit difficult scenario here. So the answer is actually a trial of atropine and isoprenoline should be given. Okay. So hopefully these type of questions will be maybe one. You don't have to like waste your energy on that, but just, like so that you're prepared for the worst case scenario. Okay, so far, I'm glad that we have discussed the cardiac arrhythmia. In the next class, I will start off with the ischemic heart disease. Ischemic heart disease, actually, there are too many important information, but that can be summarized in a maybe 30 to 40-minute lecture. So I will wrap that up in the next session, as well as the other important topics. So for today, I thank you for participating. And if you have any questions or queries, please let it know on the Telegram channel, and I will try to, meet your concerns. And do solve your questions. Okay, you're welcome. And do solve the questions back at home. Okay. All right. Thank you so much.